Hello, everybody. I'm Dr. Nasser Yusuf, cardiothoracic surgeon with interest in minimally invasive thoracic surgery. The topic, curative surgery in stage 4 lung cancer, would sound to most as impossible and to many as absurd. But I'm sure I've got you guessing, and let's look at the facts. Stage 4 lung cancer would mean that in this topic today would refer to non-small cell lung cancer, not to small cell lung cancers. And NSCLC accounts for 80% of lung cancers. Unfortunately, 50% may have already spread and are not amenable to curative treatment with a survival time of a mere 7 or 11 months and an abysmal low 10% survival rate at 5 years. The basis of treatment for lung cancers is surgery. That is the cornerstone. Stage 1, stage 2, treatment is surgery, plus or minus chemotherapy. But however, in stage 3, it's the other way around, chemotherapy, radiation, plus or minus surgery. However, in stage 4, there is no mention of surgery. When we look at the TNM classification, what is of interest to us is to focus on the metastasis. M1A deals with malignant pleural effusion or pericardial pleural effusion or separate nodules in the opposite lobe. M1B is single extrathoracic metastasis. The emphasis is single. M1C is of no interest to us because it's multiple extrathoracic metastasis. So M1 would be stage 4A, and the survival there is less than 10%. And all that we have to offer today is largely palliative therapy. In stage 4, there's nothing that can be done. That is a misnomer. Why is it so? Aggressive management of metastasis to the lung from non-lung histologies have been shown to improve outcomes. So the reverse, like the reverse lockdown, the converse also may be true for metastasis from the primary lung cancer. Primary in the lung, or secondary in the liver, or elsewhere. The classic examples would be isolated brain or adrenal metastasis. How do we go about it? When we look at the statistics, after full evaluation, approximately 7% of patients with metastatic disease will have solitary metastasis. So that's a sizable amount. 7% are only left with solitary single metastasis. That would include adrenals, brain, liver, pancreas, or the small intestine, and ipsilateral or contralateral secondaries. The primary lung cancer can be resected with curative intent. A focused metastasectomy may be considered a reasonable option. And there's very good data in the setting of oligometastasis. Aggressive treatment for some stage 4 lung cancer patients can dramatically improve overall survival. Long-term outcomes of surgical resection for stage 4 non-small cell lung cancer, a national analysis. That is a national cancer database from the United States. How do they go about it? The management strategy would be single metastasis, primary in the lung, resect the lesion in the lung in combination with chemotherapy, either before or after lung resection. The point to be noted is first, the metastasis is resected, then we go in for the lung after an interval. So in conclusion, they found excellent 5-year survival rates of 10 to 20% as opposed to a mere 5 to 10% with traditional chemoradiation. This paper, Resection of Oligometastatic Lung Cancer to the Pancreas, again substantiates and supports the view of a solitary metastasis in the pancreas and lung primary can be curatively treated. Now, types of lung resection we are looking at is a lobectomy would be the most ideal. However, depending on the comorbidities and the cardiopulmonary reserve, it may be only a wedge resection or a segmental resection. Pneumonectomy by far should be avoided because of its morbidity. If the lesion is confined to the upper lobe and invading into the endobronchial region, a sleeve lobectomy could be done, thereby saving the lower lobe. This is interesting. 48.5% 5-year survival in metastasectomy for synchronous solitary non-small cell lung cancer metastasis. Incredibly encouraging. Let's just run through a couple of cases. This is a patient, 84-year-old, who had metastasis in the liver and primary in the lung. A transarterial catheteral embolization of the liver lesion was done, followed within 2 months of the resection of the lesion in the lung. This is quite exciting that this patient had a secondary in the adrenal and the primary in the lung. The adrenal was treated without any problem whatsoever. Unfortunately, he had a problem with the pneumonectomy with the treated complication of a bronchopleural fistula. This was done elsewhere, and that's the time when they came to us, and we did a procedure which is rather uncommon, is to split the sternum, open the pericardium, separate the superior vena cava and the pulmonary artery, go behind, split the posterior pericardium, and there's the trachea, and then divide and suture the left main bronchus. Let's go back to TNM and focus on T4. It is said tumor invading mediastinum, diaphragm, hard Grace vessels are not to be touched with a barge pole. This particular patient, you can see that the mediastinal pleura is involved. It could be resected. Mesothelioma. This particular case shows a classical mesothelioma wherein the parietal pleura is involved as well as the diaphragm. And we have been told traditionally we are not supposed to take this patient for surgery, but we could effectively do a parietal pleurectomy as well as remove the diaphragmatic pleura. Aorta, not to be touched, but this particular view shows the tumor has involved the aorta. If this can be again scraped off or along with the adventitia. Inferior pulmonary vein involvement, again, is supposed to be a contraindication, but if we can open the pericardium, we can ligate and divide the inferior pulmonary vein within the pericardium. Off guideline option. This is interesting in the sense that primary tumor resection showed survival benefits in NSCLC with unexpected malignant pleural effusion. So this was an incidental finding. Having gone in, they went in and took out the primary lesion and did a pleurectomy. This patient paper, surgery for metastatic pleural extension of NSCLC lung cancer. And what did they all find? If you look at overall number of pleural effusions, a small segment, but significant, 7.5% of NSCLC, the lesion is localized in the chest, in the lung, and is resectable, along with a portion of the pleura. So patients underwent complete surgical resection of primary tumor and pleural nodules. 5-year survival rate was 16% and 21% if the resection was lobectomy, as opposed to 2.4% of 5-year survival. Pericardial effusion could be one of the other complications or metastasis. As you can see here, the heart is tense. You can't see it. You cannot imagine or visualize the heart beating. You're pushing it. As if it's a virtual standstill. And we gave a neck. Oh my God, was it the aorta for a moment we thought, because it's pumping like a fountain, but that was happily only the pericardiotomy done. And now we can go further And here you see there's associated pleural effusion that could be easily tackled. And here's the pericardial effusion. We make a pericardiotomy at the just anterior to the phrenic way nerve, and there we lift it up. There are no adhesions, free flowing fluid, completely drained, and excise the pericardium. Deal with the primary lesion, knock off the pericardium, and there you are. It's a result of almost a cure. So, in stage 4, in a particular segment, there's not only hope, there's not only end of light at the end of the tunnel. Surgery, preferably lobectomy, markedly increases the 5-year survival rate. When there is a solitary metastasis, either to the adrenals, liver, brain, small intestine, and happily enough, in the large group of patients with malignant effusion, maybe pericardial or pleural, there is that segment, 7.5%, which has a definite chance of responding and in the form of a curative nature with surgery and chemotherapy. There is hope in stage 4 lung cancer, and we all live in hope and hope to conquer it, just as we hope to conquer COVID. The heart may conceive, the head devise, the hand execute. The future is bright.